This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Well, I've got to say, I mean, there are advantages to Zoom, aren't there, with sort of screen sharing and all these sorts of things. I found that pretty useful. Sometimes it can be a bit difficult in a room to sort of share documents with each other so easily, you know, and to jump between documents, you know.
Definitely.
Yeah.
So I think we're live, so there's probably people that have logged on. So welcome everyone. If you've logged on, we're just going to wait a minute or two before we get started. $12:31. We'll wait 30 seconds. Don't want to cut your time short, Barnaby.
That's fine.
Maybe we can get started. So welcome everyone. I just wanted to first start by paying my respects to the traditional custodians of the land on which I am joining this Zoom from, and the land of the Wurundjeri of the Kulin Nation. And I would like to pay my respects to the elders past, present and emerging. So I would like to welcome Barnaby Nelson, and thank you so much, Barnaby, again for agreeing to come and speak to us. So Barnaby's going to be presenting today on his current work on ultra high risk for psychosis. And for those who don't know Barnaby, he's the head of the ultra high risk for psychosis research program at Orygen and the Centre for Youth Mental Health. So he's a practicing clinical psychologist with a particular interest in schizophrenia spectrum disorders. And his research focuses on early identification strategies, prediction of outcome in high-risk youth, etiological mechanisms, and integrating phenomenology with neuroscience, also preventative treatments. And Barnaby has published over 260 papers in this field. So really looking forward to your presentation today and hearing about your current work. And if you're ready, feel free to share your screen and we can get going.
Okay, thanks so much, Sarah. Let me see if I can put this in full screen mode.
Actually, just before you start, Barnaby, I'm sure people know, but just to remind people to pop questions into the chat or the Q&A as we go along, and we can do questions at the end. Thank you.
Great. Yeah, well, no, thank you, Sarah, for the introduction. It's a pleasure to give this presentation today, and thank you to Chris Davey for the invitation to speak to the group. So I thought what I'd do in this talk is really give quite a, a high-level overview type presentation, sort of a helicopter view of the different projects that we have underway in the ultra-high risk for psychosis area, and present some preliminary data on those different projects, and perhaps address some of the, the current issues in the field at the moment. So rather than, go into any particular study in too much detail, I thought I'd just move through things reasonably quickly. So you might see a lot of slides and not too much time on each of them, but please feel free to, ask questions at the end or to email me for further details. That's absolutely fine. I always find it a bit strange giving these webinars, not being able to see the audience, but we'll see how we go. Hopefully you can see my screen. Okay, so often the way that I organize this area of research is into these three domains pretty much. So obviously the treatment area, so our interventions, preventative and early treatments, the prediction work in this area, and etiology or mechanisms. Now clearly those are overlapping areas, but it's just a useful way to sort of categorize the different studies that and different research questions in this field. So I'll talk about some examples of work that we're doing in each of those areas at the moment. I think starting with the treatment area, the preventative and early treatments area. Now, most of this audience is probably familiar, but, what we're talking about here with the ultra high risk for psychosis population of people who are identified as being at increased risk of developing schizophrenia or other psychotic disorders in the near future, and the criteria that are generally used are based around emerging psychotic symptoms, so sub-threshold for a full psychotic diagnosis, generally termed attenuated psychotic symptoms in the field, or people with a family history of psychotic disorder in combination with functional difficulties, functional decline, or also a third group who may have experienced brief psychotic symptoms that have improved without any treatment. Now, of course, this presents a huge window of opportunity when it comes to preventative treatments. If we can intervene with this group, then of course the ultimate goal is that red line to see whether we can avert the onset of diagnosable psychotic disorder. But there's also opportunity from the point of view of understanding etiological mechanisms, drivers of onset of disorder a lot better. So there are opportunities for treatment and also for etiological understanding. And of course, the whole concept of intervening at the very outset of symptomatology, rather than waiting for a full threshold disorder to be diagnosed or advanced illness stages, is a concept that's been around for a very long period of time. So this whole area of research really kicked off in the mid-1990s, and a series of intervention trials were conducted, and there was a lot of excitement around the sort of 2010, 2012, some meta-analyses and systematic reviews started appearing. Some examples are up here on the screen of intervention studies in this field. And they were pretty positive. They're very encouraging, that initial round of systematic review. So this is one example. The Van der Gaag meta-analysis from 2013 included 10 intervention trials, all the trials that have been conducted at that date, reporting a risk reduction of onset of diagnosable psychotic disorder for about 50%, so reducing the risk by half over a 12-month period. Number needed to treat of 9, and there was strongest evidence for CBT in this group, with some indications of benefits for omega-3s and some other psychological interventions. And more cautious words about the use of antipsychotic medications. There wasn't strong evidence in favor of them, and also reasonably prominent side effect profiles, weight gain and so on, that didn't seem to warrant using it at this stage. The risk-benefit ratio wasn't favorable in that review. So there's there's a lot of positivity in the field around that time. And I think it would be fair to say probably over the last several years, 4 years possibly in particular, there's been some more cynicism about this area of research and providing treatment for this clinical population. So, this idea of a wet blanket sort of being thrown over the area, to some extent. And a number of points have been made. I'll just sort of show some abstracts up here just very quickly of some different articles, that have been more critical of this area of research. So this one, a reasonably strongly worded title, at-risk mental state clinics for psychosis, an idea whose time has come and gone. These authors were making the point that only a very small proportion of patients who went on to develop first episode psychosis actually came via sort of high risk for psychosis clinics previously, less than 5%. So they're arguing that these clinics are not particularly effective in identifying people who are at high risk of psychosis and, implementing preventative treatments within those clinics, and instead sort of advocated for a very public health type approach where we'd sort of identify and target environmental risk factors. Cannabis use is a sort of a notable one in that particular paper. They really emphasized that. Now, I won't address all of these criticisms one by one. I'll sort of focus more on the treatment side of things in a minute. But I mean, I think this particular article was an example of really, falling victim to sort of either or thinking. They were really setting up either you have high risk clinics or you have a public health, intervention type approach. But there's seems to be no reason why you can't have both in my mind anyway. So that's, they were really arguing for advancing one approach, public health approaches, over the other. But I think you can have both. Another line of research talked about how a decent chunk, a substantial proportion, about 70%, had experienced the sort of ultra high risk phenotypes, sort of those sorts of cluster of symptoms before progressing to diagnosable psychotic disorder, but a substantial minority had not. So about 30% never went through this sort of ultra high risk phase. So we're being sort of missed through the ultra high risk approach. That's another criticism that's been made. Then this point about stigma has been talked about a fair bit. Self-stigma, the idea of identifying somebody being at risk of psychosis when the actual transition rate, or the proportion who go on and develop diagnosable disorder, is reasonably modest at 10 to 15% in recent studies. So argued that the stigma is too great to really warrant, this approach. And then I guess there were a series of articles criticizing the strength of evidence for preventative interventions in this group. And they were quite sort of negatively worded. So there was a Cochrane review and a couple of network meta-analyses and systematic reviews. And this is sort of an example statements that are made in these papers. On a clinical side, individuals meeting these criteria may be informed that at present there is no evidence for specific treatments being more effective than any others. And current options should be carefully weighted on a personal basis depending on the individual. Then this Cochrane review talked about some low quality evidence in favor of omega-3, so fish oil in this group, but no high quality evidence suggesting that any type of treatment is effective, and no firm conclusions can be made. So as you can see, there's sort of some questioning of the strength of the evidence base, to put it mildly, for treatments in this phase of disorder. One of the points that's worth noting is that these recent meta-analyses took a network meta-analysis approach. And what that does is you compare each treatment that's been trialed to each other, rather than sort of pooling them together. So you have the different nodes of the different treatments that have been trialed, and you do a comparison of those different nodes, rather than pool them into larger categories, if you like, which is the approach taken as a pairwise meta-analysis approach. So I think, and I've published on this and argued against these, this recent sort of interpretation of the evidence from the intervention trials, saying that these findings don't really indicate that treatments are equally ineffective, but the other side of the coin is that all these different types of treatments that have been trialed actually might be equally effective, particularly given this sort of reduced transition rates or, risk for developing full threshold psychosis across these different studies. So, this is sort of a trope that's used in a lot of the psychotherapy, research literature, which talks about the dodo bird verdict, Alice in Wonderland's dodo bird, who sort of declares at the end of a race that everyone has won and all must have prizes. And, that is one way of interpreting the evidence here. Just because there's no advantage of one particular intervention compared to others, it doesn't mean that they're not effective. It may be that they're all equally effective and all should have prizes, as it were. So I think it's quite possible to have sort of a glass half full way of interpreting this evidence, rather than these very negatively sort of toned interpretations of the evidence base at this point. And of course, keeping in mind, it's actually fairly common across psychiatric disorders and indeed, medical disorders more generally, that a range of treatments can have a similar efficacy or degree of effect. So it's not specific to the psychosis risk area. And of course, there's also the point that these group level analyses that are conducted in individual intervention trials, and certainly when they're pulled together, may be masking sort of differential, subgroup treatment response. So we have to keep that in mind. Another thing that I think is probably overlooked in this research area in recent years is the the potent shared factors in treatment. So the role of treatment alliance, the sort of optimistic and sort of hope-oriented approach that is, you know, integral to sort of early intervention services, and also probably a point that isn't recognized enough is actually the effect of being involved in research studies themselves. So the self-monitoring and the relationship with the research assistant, that comes along with involvement in these studies. And the other point that, you know, I've argued in some recent papers is that we have to keep in mind that standard treatment, which is generally the control condition, you know, treatment as usual is generally used as the control condition in these studies, is not a fixed entity. You know, it's something that's been refined over the years, and possibly has become more effective, and that introduces, you know, a ceiling effect for being able to find, you know, additional benefit of specific interventions in comparison to these treatment as usual effects. So we looked into that last issue there in a little bit more detail in a recent paper, did this very comprehensive file audit and hundreds of cases seen at our ultra high risk clinic over at Orygen, and found that there had been longer periods of care offered and a greater degree of delivery of CBT, so more CBT in recent cohorts. And that when these changes in treatment over the years were adjusted for an analysis, the decreasing transition rate, the reduced risk of psychosis that we've seen in recent years actually disappeared. So it was more or less explained by the increase in CBT delivery and the greater duration of care that was offered to this treatment, to this clinical population. So suggesting that these changes in, sorry, it's my dog, but these changes in treatment over the years in standard care might have actually become more effective in averting the onset of psychosis. And another line of evidence for this is that we're intervening a lot earlier in the course of symptomatology in this group than we have in the past. So this is analysis from about 400 high-risk patients with a 15-year follow-up period. When we divided this group into those who received the treatment as usual, in less than a year after the onset of their symptoms, the risk of psychosis was a lot lower. So you can see the orange line there compared to the blue line, those who received this treatment, you know, once symptoms had already been in place for longer than a year or so. So providing this treatment earlier in the course of symptoms, which we're doing in more recent years in these high-risk clinics, seems to be reducing the rate of transition to psychosis. And I won't go into all the details here, but I think some of these recent papers have also set the bar very high for talking about positive benefit of these treatments. You know, they've set the bar at 50% reduction in symptoms to categorize a particular treatment as yielding clinical improvement, which I think is a fairly high bar to set and isn't sort of commensurate with a lot of other treatments in psychiatry. So, to sum up these points, I mean, the network meta-analysis approach is problematic. There are a lot of people sort of more statistically and methodologically minded who have criticized this approach. It relies on a lot of assumptions, a lot of direct comparisons that haven't actually been conducted in the primary studies. They're sort of imputed, you know, in this network meta-analysis approach. And there's a sense in which the field is really too premature to take that approach to looking at the data. So instead, a sort of a pairwise meta-analytic approach is the better way to go. So this is what we did in a recent study. This has just come out. So we did an updated meta-analysis using a pairwise approach. And indeed, the early findings of reduced transition rate when different treatments are combined still comes through in this when we look at all trials that have been conducted to date, with the strongest evidence base still for cognitive behavior therapy compared to other treatments, as that came through in this meta-analysis. Probably of note in this recent paper is that its transition to psychosis and the severity of attenuated psychotic symptoms, which seem to be reduced through these specific interventions, rather than non-psychotic symptom domains, so depression, anxiety, and so on, didn't seem to reduce in response to specific interventions over and above the control condition. So more work probably needs to be done on developing interventions that target those non-psychotic clinical domains. Okay, so takeaways from that sort of very quick run through some recent, systematic reviews of intervention trials. When pulled together, these specific trial treatments still seem to be effective in reducing psychosis risk and attenuated psychotic symptoms. Standard clinical treatment or treatment as usual is probably improved over the years. We need to focus on these non-psychotic domains and also look at subgroups. So, this is a statement that's, can be applied to so many, clinical groups, but is certainly the case in UHR. I mean, the degree of heterogeneity that exists in this clinical population. There really is, lots of subgroups within the UHR population. So how can these subgroups be identified and targeted, with a specific treatment that might provide what's most useful for that particular subgroup? And also the issue of treatment sequence. So in what sequence can different treatments be delivered? So it's in that sort of context, those issues which really it led to this next generation of treatment trials that we're pursuing at the moment. And this is one example. So we're looking at the data from this SMART trial at the moment. So I've got some preliminary data to share with you. It's not the full picture yet, but it'll give you an impression of what we've done in this particular trial. So SMART trials, in contrast to RCTs, that compare, one treatment approach to another and look at the benefits of a particular trial treatment. What a SMART trial does is it has a number of steps or a sequential approach to providing intervention. And it sort of tailors the change in treatment approach or the intensity of the delivery of that treatment in response to the unfolding clinical picture. So how the person, responds to the previous step in the treatment delivery. And we'll skip through this. So this is the design that we had in the STEP study. It was a 3-step intervention trial. It was actually our early version of this included different treatment approaches, actually including aspirin as well, but the funder, NIH, weren't so keen on that particular treatment approach at that point in time. So they're receiving support and problem solving, a very broad, psychosocial intervention. Hopefully my internet's still working. It says it's unstable, but hopefully it's still going ahead. And then the non-responders at the end of support and problem solving got randomized to either ongoing support and problem solving, so maybe they simply needed a longer period of care if they hadn't responded at that point, versus starting CBT, or what we call cognitive behavioral case management in step 2. And that took the cohort up to 6 months into treatment. And then those who hadn't responded, so the non-responders at the end of step 2, so 6 months into treatment, were randomized at that point to CBT or CBCM plus SSRI, fluoxetine, or placebo. So we were testing the introduction of an antidepressant medication at 6 months into treatment if the person hadn't responded at that point. Now, non-response and response was basically defined on the basis of continuing attenuated psychotic symptoms and no functional improvement. So still meeting the ultra-high risk criteria and not having improved by 5 points on the SOFAS in terms of functional improvement. Okay, and there was also what we called a fast fail. See if I can use the laser here. Yeah, fast fail option halfway into step 3. So people who hadn't responded halfway into step 3 were either offered an increase in their SSRI medication or commencement of an antipsychotic medication, quetiapine at that point, or a trial of omega-3 fatty acids, or to simply continue as they were. So we had a different shared decision-making approach to treatment at that point. So that was the design. Our primary aim, the main outcome point, was functional outcomes, so improvement in functioning at the end of step 2. So at the end of the CBCM versus support and problem solving comparison. And of course, in a whole range of secondary aims built into the trial as well, looking at difference in transition rate to psychosis, different symptom improvement, and we had a whole range of biological and psychological variables. We were looking at various blood parameters, cognitive biases, neurocognition, and so on, to see whether any of these variables modulated treatment response at any of the time points. Now, because it was a US funder, obviously we needed to make implications have implications for the US healthcare system. So a pilot study of the same treatment model is currently being conducted at University of California, Davis. That's ongoing at this point, and some focus groups have been set up with clinicians and various stakeholders over there. Okay, so this is the data we have at the moment. As I mentioned, we're still looking at it. So we have 342 people who were enrolled in the trial at the end, which makes it the largest trial to date, and recruited across the Headspace clinics run by Orygen, and also the PACE clinic, specialist UHR clinic at Orygen. So in line with a lot of, nearly all previous UHR studies, there were high comorbid diagnoses, so about 60-65% had comorbid mood and anxiety disorders. There's comorbidity there, that's why it adds up to over 100%. But so high rates of mood and anxiety disorders present in this group at baseline. Okay, so and moderate levels of various symptom domains. So looking at general psychopathology, negative symptoms, depression, and so on, in line with previous studies. If you look at the different sort of bands, of these measures, this clinical group is in the moderate domain. So moderately unwell from a general, clinical point of view. Again, consistent with previous work, high levels of childhood trauma, reported in this cohort, particularly emotional and physical abuse in the severe range there. Now, this is of interest to me, and I think we'll have to sort of, dig down into this and looking at the outcomes, is cognitive biases. So things like a tendency to jump to conclusions, a selective attention to threatening stimuli, external attribution style, these sorts of, psychological and neurocognitive type variables were very high in this group. In fact, interestingly, higher than a schizophrenia spectrum disorder comparison group, which I was, somewhat surprised by. Certainly very high compared to healthy controls, but the fact that this cohort rated above average compared to the schizophrenia spectrum disorder group, so those with established psychotic disorders, is surprising, and we'll see what bearing that has in terms of treatment response when we get to that point. Okay, so in terms of progression through the trial, if we look at these yellow boxes here, so 342 entered the study to begin with. NR stands for non-responders, so the proportion of non-responders who discontinued after starting step 2 was reasonably high, almost 50%, so a high sort of treatment dropout or discontinuation rate, which isn't particularly surprising given, this was a 12-month intervention trial, and the average number of sessions delivered in Headspace clinics tends to be about 6 or 7, thereabouts. So the fact that people, discontinued treatment, reasonably early on is not all that surprising. The discontinuation rate dropped, though, as the study went on. So breaking down the data, it basically means that if the people stayed in the treatment trial for an extended period of time, beyond 6 months, they were likely to stay there. So if you got 6 months into treatment, you were sort of reasonably likely to stay to the end of treatment at 12 months in. But the other noteworthy thing here is the high non-response rate. So we see 3/4, 75%, still met UHR criteria at the end of step 1, so 6 weeks into treatment, and then still a reasonably high rate, 44% of non-response at the end of step 2, so 6 months into treatment. Now that drops as things go on in the trial, but still it indicates that there isn't a fast, clinical response in terms of a remission of attenuated psychotic symptoms and functional improvement in response to this sequential treatment approach. Now, we haven't unblinded the trial yet, so we can't report on differences in outcomes between the two different treatment groups that were trialed. So we're looking at that at the moment, and I'll report on that soon. But this is combining the two different treatment arms at each step and looking at the non-responders, what happens to them. I was interested in looking at symptom change in this group, given that there was such a high sort of non-response rate categorically defined. Was there actually improvement on a continuous level when we looked at symptoms? And the story there seems to be, although we see statistical improvement, so p-values are all pretty significant across most of the symptom domains, at the end of step 1, so baseline to 6 weeks in, they're still clinically in the moderate range of clinical severity. So you can see statistical improvement, but in terms of clinical significance, it's still not a big shift at that point. The same at the end of step 2, so 6 months into treatment, still, most symptom domains are still rating in the moderate range. There are some that have been reduced to mild, but it's only further down the track at the end of step 3, so 12 months into treatment, that we see symptoms reducing into the mild band on the various different symptom measures. So it seems to take a while, in other words, to really get clinical response, looking across the different symptom measures in this clinical population. Okay, so obviously this is just a very early look, at this data. We'll get back with some more detailed analysis, and once we've broken the blind. But what we can say on the basis of this first look at the data is that we're seeing clearly a moderately unwell group from a general clinical point of view. There's not much improvement over 6 weeks. We're beginning to see some improvement 6 months into treatment using these treatment approaches of predominantly psychosocial treatments over that first 6-month period. A high non-response rates and a high treatment discontinuation rate, particularly early on in treatment. But after 6 months, people seem to be staying for the whole treatment period if they stay for that long. In terms of the high non-response rate, it might be partly a definition type point. I won't get into the details right now, but the way we actually defined non-response might have been setting the bar pretty high. And of course, there might be differences in the two treatment groups. Perhaps the high non-response rate is represented by the placebo group or the comparison group, in the different steps of the intervention trial, and those who had the more specific interventions such as CBT and antidepressant medication had a much higher, response rate. We'll soon find out. And of course, there may be subgroup differences there as well. So obviously the next steps are to unblind, this trial, to delve into the discontinuation rates in a lot more detail. Perhaps there's, represent those who actually improve quite early on and discontinue treatment for that reason. But perhaps there are also subgroups who are more severe and drop out of treatment for that reason instead. Obviously, we need to look at the whole range of biological and psychological variables that might modulate this clinical response, and treatment fidelity and treatment compliance measures are the next step there. Okay, so just check on time. All right, so we've got half an hour. So I'll just very quickly, I'll go through this section even faster, I think, but just to give you a taste really of the different types of intervention trials we're conducting at the moment with the same group. So this is called the Momentum trial, funded by the NHMRC, and it really connecting with my point earlier about needing to look at other, clinical domains beyond risk for psychosis or transition to psychosis or severity of attenuated psychotic symptoms. The main outcome in this trial, as with the STEP study I just talked about, is looking at functional levels, particularly social functioning. So can social functioning in this group be improved? And there's some work indicating that from the patient point of view, this is often the more important area, the main goal that people want to see, in response to their treatment is to improve their social functioning rather than necessarily symptom improvement, So this is often at the top of the list when it comes to people being asked what they want to get out of their treatment. So it's important for trials to look at this as a main outcome. So the Momentum trial is informed by a whole range of psychological theories pretty much, how social recovery and social functioning is based on a number of sort of psychological variables, if you like, defeatist beliefs, a sense of competence in one's own performance, degree of motivation, and also some neurocognitive aspects, including social cognition. Mario Alvarez is the person leading this, and he's drawn on a lot of sort of positive psychology type thinking and strengths-based models of psychosocial treatment delivery. So this is one example of that, self-determination theory. There's another theory called broaden and build theory, which is about sort of using positive emotions, if you like, in response to social interactions to develop confidence and to sort of build one's social repertoire and have a flow-on effect to social functioning. And also bring in a sort of, third wave, behavioral therapies, bring in sort of self-compassion and mindfulness type approaches as well. So using that whole sort of package of psychological theories, an online platform was developed called the MOST platform. And it's sort of a Facebook style thing that people can go onto. There's a cafe section here where people can make posts and sort of comment on each other's posts. It's all moderated by professional mental health practitioners who play a role there, sort of clinical psychologists, and also peer moderation plays a role on this platform as well. And there's a range of different sort of therapeutic steps or skills that are delivered through this platform. So you can see some examples up here, body and breath, a way of dealing with anxiety, relaxation strategies, how to flourish, some psychoeducation work about how the mind works, grounding strategies, grounding techniques, and so on. And the way that it works is it sort of selects these steps or suggests different therapeutic strategies to try based on what the person has found helpful previously. So it's a sort of a machine learning sort of back end to the whole system that makes suggestions based on what somebody has previously found to be useful or they've previously engaged in. So, okay, and a lot of, visual type strategies, a lot of cartoons built in there, trying to make it as engaging and as fun, if you like, to this clinical population as possible. Now, so this trial is still recruiting. We actually had to move the trial to New South Wales instead because the MOST platform was actually rolled out through all the Victorian Headspace clinics. So it became part of treatment as usual. So it became impossible to have a comparison condition in this trial. So we needed to move it to clinics based in New South Wales instead. So it's still recruiting at the moment, but based on the pilot data, which were published, there was 100%, safety reported. I mean, often there are some concerns with these online interventions in terms of, risk mitigation strategies. There were no adverse events reported, and subjective levels of feeling safe were all rated pretty highly at the end of this pilot study, and high levels of acceptability by people who went through the pilot study, which was exactly the same platforms we're using in the RCT proper. And in terms of clinical outcomes and functional outcomes, there was significant improvement in the pilot study. Of course, that was non-randomized. It was all, open label study on social functioning and life satisfaction. So the main areas that we wanted to target in this treatment approach did show improvement, significant improvement in that pilot data, and also some trend level improvement in the symptom domains. And interestingly, the targets of treatment, things like using personal strengths, mindfulness skills, social support, and so on, did seem to be engaged through the use of the platform. So they did show change from pre and post measures on those different therapy targets. So all that was very encouraging and really laid the groundwork for getting funding for this new RCT, which we're recruiting to at the moment. So again, this is an example of getting back and reporting on outcomes of that once we have those available. Okay, so this is the final treatment study I'll mention before moving on to some other work that we're doing more in the prediction and etiology space. So this one's called CANARY for short. It's basically a cannabidiol intervention trial in young people at risk. So as I mentioned, at the start, various types of treatments have been trialed in this clinical population: psychosocial treatments, pharmacological, nutritional supplements, antidepressants, and so on. But there is indication from a range of different lines of research that targeting the endocannabinoid system may be useful in young people at risk of psychosis. And obviously, this is a whole talk in itself, so I won't get too bogged down in details. But the endocannabinoid system does seem to play a role in prevention here of glutamate-mediated NMDA receptor excitotoxicity and neural damage, and does seem to be involved in many brain functions that seem to possibly play a role in psychosis risk and the onset of psychosis. So things like memory and reward processing, emotion regulation, and so on. Interestingly, CBD actually seems to counteract psychotic symptoms associated with acute THC or cannabis administration, and also counteract some cognitive impairment associated with cannabis use. So obviously, this is something that comes up a lot when talking about cannabidiol in this field, and certainly with families and so on, how it distinguishes from THC, so from cannabis use. And although it's from the same plant, it's quite a distinct chemical structure, and it doesn't have the intoxication effects of THC at all. Now, a lot of work's been done on the sort of neuroimaging and sort of neuroscience aspects of cannabidiol at the IOP in London. So they've really sort of led this area, I think. This is an example of one of their studies. Bhattacharya's published a fair bit in this area. So these were healthy controls who found, and they found the opposite effects on brain activation in different regions of the brain in response to cannabidiol compared to THC use. You can see sort of the highlighted section up here in the abstract, and also administering CBD treatment with THC actually seemed to counteract psychotic symptom or psychotic-like experiences in response to THC. It seemed to sort of block, if you like, the psychosis-like effects of THC. So it was quite an interesting series of findings Bhattacharya has reported there. Okay, so we'll go through this quite quickly. There have been some promising findings in people with established psychotic disorders. So these are generally those with schizophrenia diagnosis. And these studies reported that CBD has been just as effective, if not more effective in some of them, than antipsychotic medication. And probably the main study that's cited in this field, the largest one, was this one again from London group, Phil McGuire and colleagues, who did a trial of CBD as an adjunct treatment on top of antipsychotic medication, and found symptom reduction, particularly positive symptoms, so measured using the PANSS at the end of the treatment period. So this was all pretty promising for the use of cannabidiol in those with established psychosis, possibly as an add-on to other treatment approaches. Now, no RCTs, no trials have been conducted in the UHR group yet, but there have been a few small studies that have found benefits of CBT in terms of stress modulation. And also, interestingly, normalizing brain region activation in areas, again, also found, involved to be implicated in psychosis pathophysiology. So these different areas listed up here. So they haven't looked at clinical improvement so much, so in a standardized way, but in terms of brain region activation, there are some promising findings there. Now, Paul Amminger is really leading this area of research for us at Orygen, and he's conducted one study of cannabidiol in people with treatment-resistant anxiety disorders so far. And again, the findings were promising. This is just a summary of the changes in anxiety scores on the OASIS, finding substantial reduction in those patients with, some with mild and some with more marked changes in their anxiety scores in response to CBD. And these were people who hadn't responded to previous treatments for anxiety, so whether psychosocial or antidepressant medications. And high levels of CGI, or clinical global response, in response to the cannabidiol treatment. So this whole body of work has been, pretty promising, and that's what's led us to do this current trial of cannabidiol in the ultra high risk for psychosis group. So we're just about to start recruiting to this. The aim is to recruit about 400 patients over a 3-year period with 2 different doses of cannabidiol to check on, whether different dosage levels has a differential effect on clinical response. In terms of sites that it'll be recruiting certainly at our headspaces across Origin, and probably more widely across the Melbourne region, and also headspaces or HEAP clinics at the Gold Coast, Adelaide and Perth are also involved in this trial. Primary outcome is the change in attenuated psychotic symptoms, severity scores on the CALMS, the main measure in this area. So, they'll be randomized to either placebo or those 2 different levels, 600 milligrams or 1,000 milligrams of CBD. And as I say, that study is about to kick off. Good. So, that's my very fast run through intervention studies in this area. So, in the time I've got left, I'll talk a little bit about, I think, prediction research. Obviously overlaps a little bit with some of the sort of etiological questions as well. Now, probably the main study we're doing in this area at the moment, predicting outcome in UHR, is what we're calling the Prescient study. So this stands for the Prediction Scientific Global Consortium, funded also through the NIH in the US. Now, there's a bit of a context that needs to be explained for this whole study. So in the US, there's a group called the AMP, or Accelerating Medicines Partnership, which really is a public-private partnership bringing together pharmaceutical companies, patient advocacy groups, academic institutions, research clinics, and so on, to really, with the overall game of making fast progress in therapeutics, in treatments, primarily pharmacological treatments that are available for different disorders. And there have been a number of disease areas that have been focused on to date. So Alzheimer's disease, diabetes, Parkinson's disease, and now this whole AMP approach is moving on to psychiatry, if you like, and schizophrenia is the first condition that's been identified. So as you can see on the slide up here, there are a lot of industry partners and non-profit organizations and government bodies involved with this whole venture. So these are some of the groups that have been involved with AMP schizophrenia, as it's called. You can see them listed up here. And there's been a long lead-in period, so a significant amount of funding has really been brought together or pooled across these different groups to support research in this area. And now it's at a point of really, kicking off recruitment after all this sort of lead-in period. And I guess there are 2 central aims to this whole consortium. The first one is really to build prediction models, or models that can be used almost as clinical tools in practice to better stratify patients for new treatment trials, to test new treatment approaches, and also just in terms of targeting existing effective treatments to those who might be highest risk for psychosis as an outcome, or non-remission of UHR status, and to really be able to identify these different subgroups quite early on. And the idea is to use a whole range of different sort of assessment modalities across the clinical and the neuroscience areas, and neuroimaging, fluid biomarkers, and so on, also taking digital biomarkers into account. And the second aim is to see whether any of these measures can serve as sort of early indicators of treatment response, treatment efficacy. And the focus is pretty much on pharmacological treatments, but not exclusively so. That we can develop psychosocial treatments based on this body of work as well. So all these range of measures, we're aiming to recruit a very large UHR cohort internationally into this study over the coming 2 years. We're really, give us pointers towards mechanisms that might be at play in terms of driving outcome, as I said, in the development of clinical decision-making tools and novel treatment development. That's the ultimate aim. Now, 2 research networks, as they're called, have been funded internationally. Prescient is one of them, led by Orygen, so University of Melbourne. And the other is called ProNet, led in the US. And both of them are international networks, but the leadership for ProNet is at Yale University in the US. And there's also a group called the DPAC, which is in charge of coordination and ultimate data analysis and data quality and so on. And in terms of timelines for all of this, there's a sort of a go, no-go decision-making as to whether to move on to clinical trials under this AMP schizophrenia umbrella at around 2023, so 2 years into the study, based on the data that's collected at that point. But the initial body of work is an observational study to collect those range of measures in this group to see whether we can identify subgroups and have useful predictive tools for the range of outcomes. So as I said, I mean, there was a substantial budget that went into all of this, actually $99 million US over a 5-year period. The grant that we received was 33 million Australian dollars, and which, was the largest single NIH grant awarded to Australian-led medical research. So, a fair bit of media attention and so on around that when it came out. Now we actually have to deliver on the grant. Of course, that's the big challenge now. So I'll just very quickly summarize the plan. As with the Canary study, the cannabidiol intervention study, it has to go beyond, this is a whole network of recruitment clinics, not just single clinics can recruit the sort of numbers that we're interested in here. So there's a national network of clinics will be involved with this study, the Headspace clinics and Headspace Early Psychosis program, also involved with recruitment. And of course, it has an international dimension to it as well. So in South Korea and Hong Kong and Singapore involved on the Asian side, and we have 5 European clinics as well. The number of scientific partners have signed on to the network to contribute to analysis and so on. Not actually, recruiting participants, but they'll be involved with the scientific aspects of the study. Oh, sorry. See if I can. Sorry, Maria. I just clicked on the chat and I can't get rid of it now. Let's see what I can.
Apologies, Barnaby. I should have left it to the end.
No problem. Oh, I'll leave it on my screen. I'll get too distracted otherwise. Okay, so that's. Ooh. Oh, I'm not sure if this screen has gone a bit strange for me. Is it the same your end?
Yes, it's kind of gone all.
Okay, it's gone all blurry. Oh, there we go. Okay, this one looks right. Okay, so in these different clinics, we're aiming to recruit a sample of just under 1,000 participants, and also just over 1,000 participants we were recruited in the ProNet network. A lot of work has gone into harmonizing the research protocols, the exact same measures, scanning protocols, all the details of the assessments across the 2 different networks, and to pool the data ultimately for analysis. So it'll be a sample of around 2,000 participants ultimately. Now, okay, I won't talk about that, the governance and the structure of all this too much. But okay, I'll better finish up actually. But in terms of what we plan to do, there's these whole different range of measures which are repeated, or a subset of them are repeated on monthly intervals. And there's a 2-month repeat biomarker collection. So things like imaging, neurocog, blood samples, and so on are repeated at 2 months. And based on some preliminary analysis of existing data, longitudinal change over that time period, sort of baseline to 2 months, has been found to be useful in predicting, clinical outcome further down the track. So we'll be looking at these sort of dynamic prediction models, how change over time can be used to predict outcome longer term, and also this whole range of digital assessments will be included to look at things like tipping points in mental state. I'll move on to present a slide on that data. I mean, sometimes I use this idea of Google Maps to illustrate the idea, but this is the idea of, as Google Maps does, it yields one prediction when you first set out on a particular trip, estimated time of arrival and so on, which then updates itself over time as new information comes in, as things happen along the way, whether it, in this case, a car breakdown or what have you. But in the same way, as symptom change or various changes in neurobiological measures happen over time, or somebody's exposed to particularly stressful life events, these sorts of things can be incorporated into the prediction model, and it can update itself over time to yield new predictions. So statistically, one technique that's been found to be quite useful to do this is called joint modeling. It's been used in a whole range of different areas across medicine. We seek to sort of employ that technique in this new set of data as well. And maybe I'll finish here, but with this little video from one of the participants in a current UHR study. This is somebody who transitioned to psychosis, and this is EMA, or ecological momentary assessment, the rating of symptoms and context that the person was in over time. And if this plays, if we're lucky, it sort of shows the relationship between symptoms over time and can sort of provide, I guess, early warning signs, or I guess, red flags of sort of imminent deterioration in mental state as they occur. So that's okay. Hopefully you can see this. So the strength of these lines, the green and the red lines illustrate the sort of direction of the relationship between these different symptoms. So this is, depression, negative affect, positive affect, aberrant salience, worry, paranoia, and what's called the network density, or the relationship between these symptoms, that's represented by the black line on the right panel here, sort of increases, quite markedly. It's about 10 days before the point of conversion or onset of psychosis. So, it's just a quick illustration of the sort of things that can be done with this, this time series data, how you can incorporate change over time in this very quite granular, fashion into the predictive modeling. So, digital and passive sensing techniques are quite useful from that point of view. But anyway, I'm quite aware of time, so I've gone way over the talk period, so I better finish there. So thank you for your attention. I haven't covered everything I wanted to, but hopefully I gave you a bit of a taster for some of the, the types of studies that we're doing at the moment.
Amazing. Thanks so much, Barnaby. And I don't keep up to date with this area, so it was really nice to see that overview, and yeah, some really promising looking new studies. And was it Prescient?
Prescient, that's
Prescient.
Right. Yeah.
It's a huge study, exciting but scary.
Yes, it's we've bitten off a fair bit with that one, but it'll be a terrific data set once it has all been collected. And I think one of the big challenges with that whole study is just the number of different organizations and partners involved. So we're working pretty closely with pharmaceutical companies, and it's what's called a collaborative research grant, which means that you work pretty closely with the funding body, in this case the NIH, and they're really I think shaping or contributing pretty strongly to the science of it all, the project itself, rather than sort of here's the grant and leaving the investigators to do their own thing. It's a real collaborative venture, this one.
Yeah, nice. So we've got a couple of minutes for questions. So please, if anyone has any questions, pop them in the chat. but Maria had a couple here, so I'll just read those out for you. So regarding the momentum trial, first question, what features are used in the machine learning algorithm to select useful treatments? And is treatment selection based on engagement, self-reported improvement, or other factors?
It's certainly engagement. So it's things like completing different steps in the treatment. So, for example, if somebody's completed a mindfulness, it's what's called a sequence. If you completed a mindfulness sequence, then that'll be plugged into this machine learning algorithm, and it might spit out, oh, well, perhaps that indicates that a compassion-based approach you might find useful and engaging as well. So it'll suggest trying that. So often, people might start various steps in the sequence, but not finish the sequence. And I guess the machine algorithm that's used learns that perhaps that wasn't particularly useful or engaging for that individual. So it won't suggest, similar things. So it'll be certainly based on completion of the sequences, and also self-reported, utility of that treatment sequence. So the patient will report at the end of going through a particular therapy module, how useful did you find that? Was it useful in dealing with your stress or your anxiety levels? Self-reported, scale of rating that, and then that'll be plugged into the algorithm as well. So it's very much a real-time updating and learning, of what's been useful to that individual. It's using, as Mario often puts it, is using a lot of these marketing type strategies that are often used for no good, for bad for bad purposes, for a good clinical purpose. The same sort of things that advertisers use and so on.
Yeah, interesting. And the other question was around the cannabinoidal efficacy in psychosis. What's the clinical mechanism underlying symptom improvement? So, for example, does CBD dampen down attention, reduce anxiety associated with psychosis, or is there evidence of direct effects on lowering positive symptoms? Yeah.
Well, I think that's a very active area. I don't think people can answer that with any great confidence yet. It's interesting in the McGuire trial that I don't think there was a improvement on anxiety symptoms. I have to go back and check, but I don't think there was, yet there was, an improvement in the positive symptoms. So I guess just that trial sort of indicates it's not sort of a flow-on effect or an effect of reducing anxiety, and then, psychotic symptoms improve in response to that, but possibly more of a direct influence, which would be consistent with some of the neuroimaging findings that have been reported there, a direct reduction in activation of some regions and some networks that are implicated in psychosis, pathophysiology. So it may well be that there's more of a direct benefit here onto psychosis. But time will tell. I think, it'll be very interesting to see what comes out of this new CANARY trial. Maybe, as with a lot of these treatments, there are going to be, transdiagnostic, benefits, benefits across symptom domains. And certainly, as I said, that anxiety open label trial, we found benefits there, or Paul Amminger, led that one, found benefits for anxiety symptoms for people who hadn't responded to other treatments. So it may well be that, CBD is going to be useful across a whole range of different symptom domains. We'll see.
Yeah, remains to be seen. Thank you. And then we've got a question from Enrico. Thanks, Barnaby. What do you think of THC as an independent risk factor for psychosis, and what are the implications of that?
Well, it's interesting. It certainly is. It's well established as a risk factor, isn't it? But there's interesting in the ultra high risk area that it doesn't seem to be quite. It doesn't seem to be a particularly strong predictor of those who go on and develop psychosis from the ultra high risk phase. So one of the things I wonder about in that body of work, and it's a similar story to some extent with trauma, is that perhaps some of these risk factors have sort of already conferred their elevated risk, if you like, done their work, their predictive work to get somebody clinically to the point of attenuated psychotic symptoms or the emergence of symptoms, but they're not particularly useful from a statistical or sort of predictive point of view about who will move to the next stage of disorder, if you like. They've already conferred their risk and got person to sort of step one, in the hierarchy, and perhaps other factors are more useful in seeing what will happen after that particular point in time. So So that's one way I think about the role of cannabis in this group, given the literature. But certainly, I mean, on a more general, population level, then yeah, certainly a risk factor for psychosis. Yeah. And I mean, I wonder if you're asking that question in the context of the CBD stuff. I mean, I do wonder whether, this is one of the things going on with cannabis. Based on some of those findings, I reported that the opposite effects of CBD to THC, and how this might actually, drive continued use of cannabis in some patients. The fact that it might actually be clinically useful in terms of symptom management in one respect, and also be, increasing risk or making symptoms worse from in another respect. In other words, the THC is contributing to symptom severity, but the CBD, based on some of that data that exists in the field, might actually be tugging in the other direction, or sort of reducing symptom severity. So, and that's consistent with some patient reports, isn't it? People saying, "Oh, my voice has actually got a bit better after I used some cannabis." So, so I think it's a complicated thing. It's a complicated thing, that the role of cannabis. But yeah.
Mm. No other questions have popped up. We are a little bit over. I just wanted to quickly ask, in the STEP trial, the patients had those cognitive biases that seem to be more prominent than established schizophrenia. Did you have any further thoughts on that? Why?
It's stumped me. I'm extremely surprised by that, and it's not. It doesn't fit in, with existing literature. So, people tend to find the sort of more severe cognitive biases, jumping to conclusions, overestimation of threat, etc., to be more severe in those with psychotic disorders compared to higher risk. So it doesn't fit in with existing literature, but I'd be surprised if it's simply a statistical issue, because the sample size was pretty large. I mean, it's 340 people, and we got that baseline data on nearly all of them. So I need to give that more thought. I don't have a good answer at this stage. It'll be
an age thing.
Well, that may play a role. That may play a role. Yeah. There were particular aspects of those cognitive biases that seemed particularly severe. There were some subjective cognitive problems, so things like concentration difficulties, attention problems, memory problems, those sorts of things in that subscale. So, and also some social cognition problems contributed to that overall high rating as well. So it'll be interesting to sort of nut down on those little subscales a little bit further, and to see whether that's, driving the difference there, and whether indeed it relates to particular symptom domains, whether it's possible that, there are some, anxiety or depression type correlations that are contributing to those very high ratings and the cognitive biases. But that is an interesting finding. So we'll see. And that, of course, was one of the things we were hoping to target in the CBT aspect of the intervention. So we'll see whether that, those cognitive biases change over time in response to CBT. But,
yeah. Fantastic. All right. We might stop. So thank you so much again, Barnaby.
Pleasure.
Super interesting. Hopefully we can get you back to give us an update on the results of these new trials and projects. So thank you so much.
Thank you. No, I'd be happy to. And if anyone has any further